Hello, my name is Fiona Roach, and I'd like to welcome you to the Sports Surgery Clinic's first online conference. I hope you and your families are all well during this time. So this is our first time doing one of these conferences, so we'll welcome all feedback, good and bad, and any suggestions for any future presentations over the next couple of months. So you'll see a tab on your screen that says CPD points. Now, to get your CPD points, you have to go on to that. Now, the ICGP haven't recognised them yet, but they've assured me that it's not going to be a problem. They're just running behind at the moment, of course, like everybody else. And we will send out all your certs to you once they recognise them. So our first speaker of the evening is Professor Carl Moran. And Carl is talking about the sporting knee injuries, and he's also going to talk about regenerative medicine. So Carl has prepared a presentation for you, and then we'll be questions and answers following that. There's another tab underneath for that, so if you can ask the questions during the presentation. So now I'm going to pass you on to Professor Carl Moran. Thank you.
Hi, it's Carl here, and I'm delighted you can join us for this webinar in relation to sports injuries. This evening, I'm going to focus on the knee, in particular some current concepts around knee ligament injury, cartilage restoration, and regenerative medicine. As you know, it's being done here in conjunction with Sports Surgery Clinic, and we're delighted to have you all on board. Just by way of background to myself first, as you know, I specialise in both knee and shoulder surgery, but this evening we're going to focus on the area of knee, talking about a classical model for knee ligament injury, as well as cartilage repair and moving into biologics. I did my specialist training at Hospital for Special Surgery in New York at Cornell University. There we were able to focus on three major aspects of any significant clinical care program. Essentially, this involved clinical and surgical training in the shoulder and knee, focusing on sports surgery, but also on degenerative conditions in patients of all ages. Secondly, we did a lot of research in the area of biologics, regenerative medicine, ACL registries, and so on. And finally, we had the advantage of being able to take care of a number of professional teams and athletes for the couple of years' duration. In addition, I took on some specialist cartilage training at Brigham and Women's in Boston and further training in Belgium before I came back to Ireland. And it's really that experience that I'm trying to share with you this evening, along with the past 2 years of clinical care here in Ireland. Ultimately, this evening I did say we'd focus on three topics. They essentially are ligament injury care using ACL as a model for current concepts. Secondly, cartilage and meniscus injury with biological surgery for knee restoration. And then thirdly, regenerative medicine and orthobiologics, the special area of the field that is really growing at present.
So the first section today is really about how should we manage the injured knee using the anterior cruciate ligament injury as a model. The ACL or anterior cruciate ligament was one of the four major ligaments in the knee, the others being the posterior cruciate ligament as well as the medial and lateral collateral ligaments. Research has shown that the ACL is largely responsible for keeping your knee stable during activities such as turning, pivoting, and twisting. Most people do not require an ACL for unidirectional, i.e. straight ahead activities, such as walking or even jogging on a track or road. However, as you'll be aware, most athletes will require their ACL to participate in highly agile sports such as Gaelic games, rugby, soccer, hockey, and so on. An ACL tear is one of the most common type of knee ligament tears we see. There are many ways to tear your ACL. Although some ACL injuries do occur as a result of being struck on the side or front of the knee, most ACL tears are actually non-contact in nature. They typically occur during a rapid pivot to stop and change direction. Usually the athlete will describe accelerating or decelerating rapidly, turning, pivoting, or twisting. When the ACL actually tears, the knee tends to buckle or give out, and frequently the patient will describe a pop or even hearing one, and swelling will subsequently occur. There's evidence also to suggest that the incidence of ACL tears is increasing over the years due to many factors. Some of these may be sport-specific or environmental. Some research also shows that young women are more prone to ACL tears than their male counterparts. This may be due to anatomical difference, landing and cutting mechanics, and some studies also show that tears are more common during certain times of a woman's menstrual cycle, for example. However, we must also recognize that we're investigating and imaging many more knees than we did so in the past, given the increasing emphasis on organized sport, and this too is impacting on the frequency of the ACL tear diagnosis being noted. In terms of taking a history then, what do you need to look out for? Well, If your patient has sustained a knee injury while pivoting, turning or twisting rapidly, or heard the pop I mentioned, or experienced swelling, there's probably a high chance that they tore their anterior cruciate ligament. The knee might not swell immediately, but instead might swell an hour or two after this, so it can be a little variable. If you suspect that your patient has suffered a ligament tear in their knee, or more specifically an ACL tear, I think you should probably encourage them to use ice on the knee to reduce swelling. Next, getting them to apply compression via stocking S-wrap, not too tight, and obtain a pair of crutches if at all possible. I suggest using the ice for maybe 15 minutes on and 10 minutes off over the first 2 to 3 days to minimize swelling. Immobilization or bracing of the knee after an ACL tear is something I'm also asked about, but it's typically not necessary. Instead, I prefer to encourage moving the knee to help prevent stiffness and muscle atrophy. The faster the patients gain back painless mobility, the better. It helps us proceed with surgery, and also the less muscle atrophy and weakness they will have too in the long run. In terms of further assessment, I suppose the patient should have their knee examined and have x-rays taken within the first few days following a severe knee injury. Having a swollen knee is the most common finding in a severe knee injury. Usually a physical examination alone will confirm the presence of an ACL tear and a Lachman test in anterior drawer, but an MRI is also useful to confirm the presence of a ligament tear. And it will also help show if the patient has damaged their meniscus or damaged the articular cartilage to a substantial level. But Cathal, I suppose answering the patient's questions, what do you need to know about that? Well, first and foremost, bear in mind that the indication for an ACL reconstruction is not merely the fact that one has an ACL tear. Many adults think, or at least are told by friends, that since the ligament is torn that they need it repaired or reconstructed. To be honest, this isn't entirely true, and it's not what scientific literature on ACL tears reveals. In athletes and many patients overall, an intact or functional ACL is usually necessary to compete in certain sports with cutting, pivoting, or twisting. Our GAA, rugby, hockey, and other professional athletes, I suppose, always opt for surgical repair of the ACL tear. The findings over the years in my own hands have that really they can't achieve adequate stability to perform without it in many cases. However, in many people with lower demands, we do explore possibly managing without surgery. Some adults can return to playing tennis or even gentle skiing without needing ligament injury. We always do encourage patients to decide to take this route to work closely with you, their therapist, and possibly consider alterations to lifestyle. We certainly don't like to see repeated instability events. We don't just say this for comfort reasons, but also because research has shown time and again that recurrent instability events leads to increasing cartilage and meniscus damage and worse outcomes overall. If there is a sense that this is the case for your patient, after a trial of rehab in adult patients who try to go the non-surgical route first, ACL reconstruction is usually the way to go. The next issue are partial ACL tears, but I suppose the key issue here goes back to the same point, whether or not there is symptomatic instability present. Symptomatic instability is a sense of the knee giving way. Many patients do like to try initially, but if they come back and say that the knee is giving way, even if the MRI was suggested as a partial tear, in that case, we'll often go towards an ACL reconstruction, because in these cases, really the patient does require the ACL for adequate stability. Another second issue is typically the athletic population and the timing of the injury, whether it's in or out of the season. Someone who maybe have a game or two left to play with a partial ACL tear might try and rehabilitate to get back, but it's very unlikely they're going to get through a full intensive season with a high-grade tear. And usually, rather than risking further damage, we usually consider going ahead with an ACL reconstruction and hopefully just missing one season out of play. The next question that often comes up is ACL injury in teenagers and adolescents. And this is another area that's important to consider. Traditionally, I suppose the experience was, or the advice I got coming through was to wait and see how matters go over time and try and buy some time. But I think our understanding has somewhat changed over time. We now recognize that limiting further damage in cartilage and meniscus is very important. Furthermore, I suppose nowadays the majority of children and adolescents we see are very active, more so than ever before, and suggesting that we just wait and see what might work out really doesn't tend to work out very well for anyone, the patient, the child, or the family, or indeed as the doctor down the line. And I suppose finally the aspect arises then of the same old issue regarding osteoarthritis and asking me whether or not, or should the patient get it done because they don't wish to get osteoarthritis. Well, I have to admit that really patients do need to know that avoiding osteoarthritis is not really a good reason for undertaking ACL reconstruction in isolation. I suppose, like most things in life, we're particularly bad at predicting the future. However, because the knee is taking a big biological hit as well as the mechanical hit at the time of injury, there does appear to be a tendency towards degeneration of the knee over time in certain people. We do also have the sense that avoiding repeated instability events and that leads to more cartilage and meniscus damage is an appropriate step until we identify biological agents that might be able to slow the process of degenerative change. Question then often arises for me, well, which graft do you use? Well, there are a lot of grafts in use now. Typically, patella tendon grafts or hamstring grafts are the most often you'll see used. I occasionally also use quads tendon graft and even allograft, i.e. from deceased donors, maybe in revision cases. But for me, the patella tendon graft is the go-to graft. I think there have been trends over time towards hamstring use, and now that pendulum is kicking back again towards the patella tendon graft. And the bottom line is shown again in this paper in January 2020 in the Knee Journal. And these guys looked at factors associated with revision following anterior cruciate ligament reconstruction. And since in a systematic review of registry data of all national and community ACL registries published to date around the world. And the bottom line is that younger age and the use of hamstring tendon grafts are consistently reported as risk factors for failure. I suppose in the sports we see in Ireland, be it Gaelic games, rugby and so on, those knees are stressed like no other sports in the world really. And the bottom line is the patient needs to know that they're going to get the best chance of survival of that graft in the long run. And for me, the patella tendon is the way to go. But what other factors can impact on the outcome of surgery? Well, the outcome measures that we need to look at are return to sport to the same level, staying in sport, functional scoring, need for further surgeries and long-term data follow-up. And specialist care really has been shown to impact on all of these parameters. Factors that are very important to look at and probably explain why outcomes of specialist centres may be better than those outside, because looking at concurrent injury of articular cartilage and meniscus, which we'll chat about again later on, identifying multi-ligament injuries, dealing with MCL tears, lateral collateral ligament tears and so on, working in very careful unison with rehabilitation specialists, having rehabilitation guidelines, physiotherapy guidelines, perhaps biomechanical checks at various timelines following the injury and so on. You'll be aware of our sports surgery clinic biomechanics program, which we feel helps patients a long way towards getting better, particularly as it gives them some objective data at various stages during the rehab. The next then is the psychological impact, because really this is untold for many young athletes. They're often not good at describing their feelings or their worries, but they often put on their best show during consultations or even physiotherapy visits, but it has been shown to have a major impact. And I suppose that, along with motivation and patient factors, are key aspects we all need to work together to achieve the best outcomes. You will be aware also that there are other areas that we tackle. And what else can we do to get the best outcomes? That some people are reading now that doing the ACL alone might not be enough. Well, there's one story that really has evolved a little over the last couple of years. This concept of doing an extra-articular augmentation of the anterior cruciate ligament reconstruction. And essentially, there are a few high-risk groups that we know for re-injury following ACL surgery. I suppose these groups tend to be either people undergoing revision ACL surgery, patients who are very lax or have a high-grade pivot, or those young patients undergoing ACL reconstruction who participate in high-intensity sports involving a lot of cutting, side-to-side work and pivoting and so on. And addressing this, I suppose there's a lot of current interest in application of the additional stabilization via the anterior lateral ligament reconstruction. It does involve another incision over the lateral side of the knee, but for these cases, we feel it's worthwhile and it can provide some additional stability. I suppose there is admittedly, however, some mixed lab and clinical data to support this, and we're continuing to evaluate it. There are questions over whether it's really new. It has been tried previously in the past. There's a thought process now, however, that our techniques and perhaps our instruments might allow us to get slightly better results, but it's an area we're going to continue to monitor. So I suppose, how then do we extrapolate the ACL model to achieving the best injury outcomes for other patients with an injured knee? That might be a medial collateral ligament injury, an LCL, a PCL, patella instability. Well, it's really about individualizing care. But from what I've described here in ligament injury, there are a few key issues we can work together on. The first is to educate ourselves so we can explain things in simple terms, and hopefully chats like we're having this evening will help there. Working as a team is important, and hopefully, again, these seminars open these pathways of communication and trust. The athletes and patients always note when physiotherapists and surgeons are working closely together, and I think they can pick up on that. I think it's very important to understand what can be rehabilitated and recognize those patients that cannot. Understanding the injuries, understanding the nuances examination are very important. And I suppose recognize that patients are people, and that there's a lot more to getting someone back on the field than inserting a new graft or repairing the soft tissue in a few months of exercise. As I said, trust and investigation is the key early on if you have any doubts. Start movement and prehabilitation once the immediate period for rest, ice and elevation ends. Take time to address any mental concerns. Give the patients time to chat and reassure them. And communicate, communicate, communicate. If you feel there are any problems before surgery, after surgery, or never, I'm delighted to chat about them, and my team and I will always be delighted to follow up and help you any way we can. So now we're moving into the second part of our discussion, and that relates to cartilage and meniscus injury, and particularly biological surgery for knee restoration. So the first area is probably about meniscus tears, and I suppose what do you need to know about meniscus tears? Well, there are two classic forms of injury of the meniscus. There's either the degenerative tears that we tend to see in later life versus the acute injury that probably happen in younger patients, athletes, or patients who have a clear diagnosis of trauma. I suppose you need to be very aware of just the MRI diagnosis. There's so many MRIs being done nowadays that many of these are chronic degenerative tears that will be picked up in any of us over time. The ones to watch out for are the patients with symptoms, and it really goes back to taking your history examination and doing things in the normal manner. As I say, in terms of treatment then, well, really it goes down to patient-specific treatment, managing the symptoms and the function of the patient. At the end of the day, the patient comes to us with pain, swelling, clicking and so on, not necessarily with the MRI report, although that isn't happening with increasing frequency. I suppose the next thing we need to understand is the impact on patient. We always would tend to suggest a period of non-operative conservative care, if we can go with that. But for many patients, whether they exhaust this after 6 to 8 weeks, or whether they have acute symptoms that we have to go ahead and deal with, well, we're looking at either debridement or repair scenario. And people ask me all the time whether or not their meniscus can be repaired. Well, this comes down to a number of factors. I suppose, first of all, whether or not it is actually in a zone of the meniscus that biologically will heal, whether or not they're willing to take a period of time out to protect it with weight bearing, whether or not they have any other conditions, whether any pressures to get back to work, to games and so on. Of course, it's always a preference, particularly young athletes and young patients, to repair where possible. But in the majority of cases, a debridement is the more suitable option. The other big question that comes up here is the patient asking whether having a meniscectomy can cause osteoarthritis in the knee. Of course, we discussed this with them, but in many cases, they'll go back to their physiotherapist and GP and ask this again. And really what I try and emphasize to the patient is really the only part of the meniscus that we will ever actually debride or remove is the torn part, the dysfunctional part, the part that's causing the pain. I think in the modern area of specialty surgery, there is nobody going to go in and remove a functional or important part of the meniscus that would be of importance to the patient. It's really the damaged part that's removed. There is an increased association between people who lose their meniscus. But remember, the horse is bolted at the time of the meniscus being torn. That's when the function is lost. In terms of one area one really needs to look out for, though, in terms of meniscus tears, is that of a swollen, a locked knee, an acute injury with where the patient may not be able to fully extend their knee and so on. Classically, again, a young person, often on the field of play, be it the GAA, the rugby field, or so on. And it's important if you do come on such a locked knee, where the knee tends to swell up in the first day or two, that you consider this. And this requires not just an early MRI scan, but also early intervention to repair it. And that's something that we would regard as a relative repair emergency, and intervention is required. But moving on then to what about a particular cartilage injury and the increasing interest of patients in biological knee restoration? Well, looking at this evening, we'll look a little at the science of cartilage injury repair, the treatment options, the patient assessment and decision-making process, as well as the importance of data collection for supporting decision-making and future directions. I want to be very clear, though, that this discussion is not about osteoarthritis. Osteoarthritis of the knee in older patients should be treated with knee replacement, be it total knee replacement, as you see here, or partial knee replacement. Once you go into your late 40s, 50s, and so on, your potential for regenerative healing and so on is very much limited. And chasing biological options in the surgical form of this group probably will be left with limited outcomes. In terms of knee replacement data, people are always worried about this, and I suppose The big thing is survival. They'll ask, well, won't it fail in 10 or 15 years' time? Well, no, look at this data. This is from a systematic review and meta-analysis of case series and national registry reports. And here we see 96% 15-year survival, 95% at 20 years, and 90% at 23 years. So knee replacements do very well and last a long time. Our key issue is to try and get people out to the stage where it can be of benefit to them. And there's an increasing interest in patients and amongst people who are interested in this field are coming up with options that help patients prolong their activities and function for as long as possible. But back to articular cartilage defects and dealing with those. But what I'm really referring to are the isolated defects. And by articular cartilage, I refer to the lining surface. You can see on the right of your screen here, this defect here. This is essentially where the articular lining of the knee is gone, and you're looking at the bone underneath. And we believe it's the exposure of this bone that creates pain in many patients. So I suppose patients nowadays, like everything, it comes down to, so have we got a cure for everyone now with this? Well, it's not quite as simple as that, because there's more to it. I'll talk about the lesion itself in a minute, but patients' expectations and activity levels are so important. The patient that has pain in everyday activities, well, they're obviously a clear candidate, but if they're patients who are hoping for marathon running, pushing on, really pushing hard in these knees into their late 40s, 50s and 60s, well, we have to treat these with a certain amount of caution. We also know that healing following this period is important, and obviously this is a key aspect of the regeneration. It's this that we're trying to drive. So when I work through somebody with the cartilage defect, I see a lot of them being referred from around the country now, and also from my own colleagues. I suppose one of the key issues I need to look at first is the alignment of that patient, whether they're straight, whether they're in valgus or varus. Secondly, what is the knee stability like? Is the ACL intact? Is the PCL intact? Are the collateral ligaments intact? Meniscus integrity is the next thing. By that I mean, are the menisci on the lateral medial side working? Next then, a superficial defect of the cartilage surface versus osteochondral. And I'll get into a little this more moment, but ultimately osteochondral means bone and cartilage, and really we feel this is the main generator. So looking at the surface alone won't sort things out. What about prior treatments? For example, we know that Maris stimulation or microfracture, who was popular before, is associated with an increasing risk of a failure of a repeat treatment in the case where it was done as a primary procedure and did not work out. Finally, then, patient expectations. Many patients expect to come to surgery now in keyhole surgery to be better and to be able to walk out of surgery the next day or to be flying within a week or two. It's important to know that we need huge input from them, and also that they also have to be aware they'll have to have a period non-weight bearing. And ultimately, a key goal of it is to have people comfortable in everyday life and recreational activities. Higher level activities and intensive sport are always a bonus. So they're the key issues we have to work through. But the other issue is what lies beneath. I suppose this is a classical picture that you see at arthroscopy of the defect. But what I'm also interested in is what you see the red arrow pointing at, and that's essentially the bone marrow defect that lies beneath. These are areas that I really feel the pain is coming from, and it's this bone marrow problem, osteochondral, the bone aspect of the problem, that really needs treating. In terms of the options then, well, you'll know of debridement and lavage. This is essentially a routine arthroscopy where we go ahead with the clean out. The second then is marrow stimulation. That's essentially where we drill into the subchondral bone to try and bring cells and other abstract proteins out to try and grow cartilage, maybe not natural chondral cartilage, but actually some sort of fibrous cartilage or repair tissue. Across then we start moving towards the next treatment you hear me using, cells, or more particular osteochondral autograft, where we take plugs of bone from within the patient from a non-weight bearing part of the knee and transfer them to the defect. And finally then we've got osteochondral allograft for large defects. Essentially what happens in this scenario is that we take the plugs of bone or large plugs of bone from deceased donors and transfer them into the defect. The wonderful thing is, as we're going from left to right across the screen, we're becoming increasingly restorative and in terms of the joint nature and its function. The issue, however, of course, is that there's increasing morbidity and problems as we go across. So that's why I suppose it's helpful to consider these surgeries in a specialist centre and with the right advice for the patient. In terms of, as I mentioned at the start, alignment, before we go down the line, if there are some alignment issues, we may consider doing an osteotomy. That's a realignment surgery along with the cartilage repair procedure. And before we go into that aspect, we'll usually try a brace, which will change the alignment of the limb, and the patient can try this for a number of weeks before going ahead with the final surgery. And all of this helps us feed into our program of care. So I suppose my questions for the patient or athlete when they come along to see me, and maybe ones you can start to probe with them, I suppose, really, haven't the appropriate least invasive treatment options been tried? Is the magnitude of symptoms great enough to warrant surgery? It's very hard to bring someone from 9 out of 10 to 10 out of 10, but that 2 out of 10 might easily be brought up to 8 or 9. Is the patient a suitable candidate for surgical intervention? Are they correct weight? Are they motivated? Are they committed to the surgery and particularly the rehab? Next then, key aspect is there a procedure with a meaningful upside? By this I mean, will it make the patient better? I mean, it's very easy to go ahead with surgery, but the key aspect, of course, is deciding whether the surgery, after they're going through the treatment, going through the rehab, and at the end of it all, will leave them in a better state than they did before they came in. And these, as you can imagine, are key issues that really cause people to think and that we have to work through together. And finally, does the patient understand and have they considered the pros and cons? It's very important, however rare they are, to consider any of the risks that might be involved. And these are key aspects that we try and go through them at the time. Before we get to surgery, I suppose we do try cortisone and local anesthetic. We can try hyaluronic acid, a lubricating gel. We now use platelet-rich plasma. And occasionally hear people asking about stem cells. I'll come back to stem cells and the regenerative aspect of the talk, but really the key issue that I need you to take home tonight is there is no such thing as stem cells. There's cellular therapy, there's bone marrow aspirate, there's platelet-rich plasma, but true stem cells are not available other than in randomized clinical trials around the world anywhere at present. Chondroplasty, well, it's just the first thing we might consider, and I suppose this essentially is a debridement procedure. And with the debridement procedure, what we're hoping to do is just remove the loose flaps from within the bone. I will often use this as a first-line treatment in athletes or other patients who might want to keep things as simple as possible and see if the simplest procedure works out for them over the following few months. For years, people might have added a microfracture into this, but to be honest, I think a lot of the data now around isolated microfracture suggests that the results do fall off over time and that the outcomes of second procedures after failed micro are not as good as primary. Where I do it then, I actually go to what's called an augmented microfracture, where we use a clot of essentially a gel, of platelets, of blood cells and so on. We inject it over the lesion, and this data from registries around the world is showing improvements over microfracture alone. So I think if microfracture is being used, it probably is more appropriate to be called augmented microfracture or augmented marrow stimulation. The big one you'll often see me going for is osteochondral reconstruction. And this really, I have to say at the moment, is the mainstay of a lot of my cartilage work. Essentially, this involves transferring cartilage defects, transferring cartilage plugs from a non-weight-bearing part of the knee to the weight-bearing site. This can be done in isolation through large plugs or through a number of mini plugs to essentially fill the weight-bearing or the injury site. Patients always will ask me, well, what about the donor site? Well, we focus on taking the cartilage and bone plugs from an area of the knee that's non-weight bearing. And ultimately, by transferring them to the defects or injury site, it does tend to improve patient outcomes in the correct population. What kind of results have I seen? And what can you tell your players? Well, I tell them the return to sport is about 61 to 93% in literature. I probably would say it's about 7 out of 10. That's what I've seen myself. So by no means is it a guarantee. But still, it's for 7 out of 10 chance of getting back. If you're not there at the start, well, obviously that's a reasonable chance. But I do tell them it'll take more than 6 months and maybe 9 to 12 months or more with hard work to get back. Here you can see a second look arthroscopy after a couple of plugs were placed, and this shows where it's well bedded in. Here you can see where it's actually well bedded on the MRI scan as well. Next one I see, the MRI reports osteochondritis dissecans. Well, what's this? Well, this refers to a particular form of osteochondral defects which occur typically in young athletes in the age of teenage years, typically turning up between the ages of maybe 10 and 18 years of age. Essentially, we know at this stage that it may be due to issues of blood supply, overactivity, and many other possible reasons. But the bottom line is we're not entirely clear why it happens, and we're not entirely clear why some patients are painful. But we do know that the best outcomes are seen with early intervention. We might try 6 months initial rest and don't immobilize. I really try and encourage people not to be immobilized. I've moved a long way from that because I really don't think it helps the kids or the rehabilitation people to try and get them through it. We might initially try some arthroscopic subchondral drilling to promote revascularization, and then eventually look at arthroscopic debridement and fragment stabilization with the screw or mini plugs. This is how we do it here, by placing the plugs through the bone and cartilage defect from the surface into the actual deep-seated bone. This is the dual benefit of actually securing the lesion, but also having the secondary effect of having a regenerative plug rather than using plastic or screws across the actual plug site. Here we can see a classic case, a 15-year-old camogie player struggling for a year. You can see here, no longer able to play. The bottom line is you see some edema here in the bone. You see the dead bone here. In this case, what I would have gone in is looked inside the bone. You can see the lesion site here, where it's a little yellowed. You can see it raised here. I go in and out with my, to create an area where I can actually put my plug of bone into. This is actually at the injury site with my initial tool. This is done with a mini open approach. I then go along to the outer aspect, non-weight bearing aspect of the knee, take plugs of bone, and eventually take a number of them and start transferring them into the defect site. This is what the donor site looks like at the end, the site which gives the plugs, and this is what the repair site looks like. And the hope and expectation is that these patients will get back to play, and indeed in this case, this young girl has been back playing now for the last year or two, getting a break this summer no doubt, but other than that, delighted to be back. But this does take time between the surgery, buy-in from the parents and so on, but it can be achieved. So again, how do we decide to do what? This is what you probably all need to know. Well, in terms of debridement, I use in the first line my in-season athlete, lower demand levels, nuance of mechanical features with a loose body, Maris stimulation. Augmented Maris stimulation, I should say, is the first 1 to 2 centimeters first line treatment unless there's subchondral change. But when that subchondral change is present, I will go to the osteochondral autograft procedure. We'll hold scaffolds or allografts for larger defects. Managing expectations in athletes is critical, however. I suppose like everything in life now, people imagine that they can come in, flick the switch and everything gets better. It's really not a matter of that. I prefer to look at the dial like this. It's one where you can gradually help improvement in terms of pain and function, even if you cannot resolve it fully over time. Decision-making the athlete. Pain only with sports, I tell them, and if they have an acceptable level of performance, hold off. If they have an unacceptable level, I suppose, think hard if they're still able to play. It's when they're unacceptable pain with activity of daily living and their sport really is in jeopardy entirely, then we go ahead and treat. At this rate, I suppose the vast majority will be very happy. I tell them sports are a bonus, although no doubt most of them are trying to get back to that level. I suppose the risk of re-injury is sports specific, heavy impact, cutting sports and so on do take their toll on the knee, as does marathon running, etc. A key aspect I suppose I need to mention here is the importance of dedicated rehabilitation protocols. In the early stages, knees tend to swell. But a key aspect of doing well is getting integration of the new cartilage, of the new bone and so on, and following the protocols to the letter of the law. We're delighted to work together. We have physiotherapists taken on board in the practice to work with this, not to do the therapy, but indeed to be able to answer the questions of all the therapists in the community so that we can work together to get patients the best level of care. A key aspect of regeneration is actually rehabilitation. Putting pressure on tissues, using them and so on is a key part of them healing. So these protocols are available on the website and are always made available for any patients undergoing care. We also keep this going with a parallel research arm. We have a couple of students at the moment focusing on this area. One particular student is finishing up his trial in relation to meniscus tissue engineering at the moment, just finished his PhD, and the idea there was we were trying to recreate meniscus or meniscus repair device through the use of scaffolds and so on. We're moving these more and more towards clinical trial all the time. A clinical trial we did undertake was one with the Royal College of Surgeons. Professor Fergal O'Brien and I were collaborators on a scaffold that was generated over the last few years, eventually taken through lab. Again, then this scaffold was used as a plug in horses in the same way as I showed you the autograft. And finally, we went ahead with a clinical trial and implanted it in a number of patients here at Sports Surgery Clinic. And I'm delighted to report how well they've done over the past couple of years. All have been delighted. And so it does look like we're moving in the right direction here also. So the third aspect of our seminar relates to regenerative medicine and orthobiologics. I myself am extremely passionate about this field and how it can be harnessed to enhance outcomes in knee and shoulder surgery. I suppose going back, my own scientific and doctorate studies have focused on this area for a long time, and this involves some time at University of California, San Francisco, and the Mayo Clinic in the US, as well as cartilage surgical training in Belgium and the Brigham and Women's Hospital in Boston. This has given me some insight, I think, which I can share with you now as we grow this area in Ireland. What is regenerative medicine? Well, regenerative medicine is an exciting and emerging discipline, I think, which aims to develop novel therapeutics to repair and regenerate damaged and diseased organs. These therapeutics, I suppose, utilize cells, genes and proteins, biomaterials and other biologically active compounds. As you can imagine, orthopedics and sports medicine is one of the most promising fields for this to take effect, and more we're looking at ways we can enhance healing without going straight to surgery. Not only that, we were looking at ways the way it might help our outcomes after rotator cuff repair, cartilage reconstruction, and so on. And I suppose examples of impact include repair of damaged tissue, as I say, speeding up tissue growth and regeneration, reducing inflammation, and essentially improving blood flow by creating new blood vessels. The big caveat to all of this, though, is that our patients need protection. With Dr. Google out there now and being able to access information, there is some danger. And I suppose experience across Europe and the US demonstrates an important need for regulation. There is a real worry that because patients can be in such desperate need, they can reach out. And there tends to be an issue around bias in terms of evaluating results. If patients go and pay for these type of biologics, if they're off-label, obviously there's a clear tendency to hope within themselves that they really do have effect. But instead of this, the proper use of these products really is within properly established centres. What are the key types of therapies? Well, the first is that of cellular therapy. And I suppose the first thing when people think about cellular therapy is always stem cells and stem cell therapy. But the very important thing is for you to not let anyone tell you or any of your patients that they're receiving true stem cells that will regenerate new tissue. This is bottom line, I suppose. This is a lie. And I suppose the bottom line I'd say is to avoid practitioners who say otherwise. There are no stem cells really in use in Ireland or in any other countries at the present time. There are some in clinical trials, admittedly, but the majority of cell sources that are being described are actually from bone marrow, from adipose tissue, and other similar sources. These cells often are delivered as part of just the constituents of many of the other products that also make up what is transferred into the patient. And really, these sources can be enhanced as cells to enhance signaling, repair, and anti-inflammatory processes, medicinal signaling cells, but they're not stem cells in the hope that patients have of actually reproducing or creating new tissue. The next thing, I suppose, is the concept of the use of lipogems. Lipogems is a source of adipose tissue or stem cell therapy, and it essentially involves taking small amounts of tissue from areas of the body, such as the stomach or thighs, and using a special process, cells are extracted from this tissue and injected into areas of your body that have become damaged through wear and tear, injury, or disease. Adipose tissue therapy can also be used as additional treatment alongside other orthopedic procedures to help with bone and tissue healing. You'll note, though, I'm not using the term stem cell therapy. It is cellular therapy, and this is a product or treatment that has been approved by the FDA in the US as well as CE marked in Europe, and we're now making it available to patients in Ireland, but only after careful explanation of the possible benefits and the data available. I do not in any way to suggest that it will be massively used in all patients as a magic bullet, but we are certainly at the stage now that we would prefer to see it used properly to educate and share what we do and don't know through our institute, rather than have desperate patients seek out poorly validated treatments they find on the internet, be it in Ireland or elsewhere. The next area to mention is that of platelet-rich plasma. It has been around for a while, and I suppose one of our most recent research reports here at Sports Surgery Clinic, just published this month, evaluated the role of platelet-rich plasma in ACL surgery. By way of background, platelet-rich plasma, or PRP, is a concentrate of blood proteins derived from whole blood. As a concentrated source of plasma, it contains several different growth factors that can promote healing, and current literature has exhibited that PRP injections are relatively safe and can potentially accelerate or augment the soft tissue healing process. The use of PRP in the treatment of rotator cuff tears, osteoarthritis of the knee, lateral epicondylitis or tennis elbow, hamstring injuries, and Achilles tendinopathy has all been reported. But I suppose one of the bottom line messages I need to get out is that we now know that no two PRP preparations are ever the same. It's not even the same from the same patient if it's produced in different days. And if it is going to be used, it should be done so in a well-validated and appropriate manner. Clinicians must know the type of product they're using, the number of white cells and other constituents, and must outline to their patients the potential risks and benefits of using it. I'm not always clear that this is taking place, yet I think it is something that really must be understood by the wider community, including patients, GPs, and physios. Our patients are going to hold us very much to account over the years ahead, and the standards that apply now might not be the ones who are held account to in the years ahead if we're not careful. So how then do we keep our patients safe? Well, Thankfully, this is a global effort, and I'm pleased to report that we are part of a global effort in this regard. Earlier this year, I joined a group of colleagues around the world to discuss this very topic in Carlsbad, just outside San Diego in California. And as we found out recently, for better or worse, our world has become very small, and sharing information and evidence is just one of the upsides of this. In essence, an alliance has now been formed between the International Cartilage Regeneration and Joint Preservation Society here in Europe, the American Orthopaedics Society for Sports Medicine, the Arthroscopy Association of North America, and the American Academy of Orthopedic Surgeons. And this has become known as the Biologicals Association. And I suppose our mission in this is to foster a shared and coordinated efforts to speak with a unified voice in the use of musculoskeletal biologics environment, to advocate for the responsible use of biologics in clinical practice, to spearhead standards of development, and to assess and report on the safety and efficacy of biological interventions. And I think this sums it up very well.
As a next step in this process, my colleagues and I are in the process of launching what will be known as the first regenerative medicine centre in Ireland. The purpose is really to provide a safe and effective musculoskeletal biologics environment, advocating for the responsible use of biologics in clinical practice, and ensure that those treatments that are available globally are now made available in Ireland also. Ultimately, we will be providing platelet-rich plasma, adipose cartilage cell therapy, as well as cartilage transplantation techniques. For qualifying patients, these can be used in treatment as standalone injections, enhancements to surgical procedures, or surgical procedures themselves, such as when I do cartilage reconstructive surgery. Where patients are interested, we'll be able to discuss the pros and cons in full with them and hopefully collect our data so that for the first time it can be demonstrated to be undertaken in a very clear and transparent manner. If any patients are interested in this, we should be delighted to chat more or guide them through the process.
So in summary today, I've taken you through three broad sections in relation to knee surgery in the context of orthopaedics and sports medicine. We've first looked at a knee ligament injury using ACL as our model. We've looked at cartilage and meniscus injury as well as biological surgery for knee restoration. And we've gone through a good discussion around regenerative medicine and orthobiologics. Further information can be found on our practice website, www.cahaljmoran.com. On the site, you're going to find a lot of patient information, referral pathways, educational content, and other information around rehabilitation programs. If we can help you at any stage in the future, please don't hesitate to give me a call. And of course, I'll be delighted to take any questions you have now regarding today's seminar.
Thank you, Carl, for that great presentation. So we're just going to go through about 4 questions. So the first question is, does it matter how long after an ACL injury an ACL repair is carried out, whether that's weeks, months, or years?
Yeah, I suppose there's a lot of discussion around this, Fiona. There are a couple of key things that we always like to address. I suppose in medical speak, we like to ensure that the knee is back to what we call normal homeostasis. That essentially, I suppose in layman's terms, that means that we get the swelling down, that we get full range of movement, and that it's the functional state that it won't respond to a second hit through surgery. I suppose in other ways, though, there are other factors that guide us. We do know, for example, that each quarter, we've done research even here at SSC, which demonstrates that each passing 3 months can result in recurrent injuries. And with each instability event, we see increase in cartilage and meniscus damage. And I suppose as cartilage and meniscus damage and prevention of cartilage and meniscus damage is one of the key reasons for undertaking ACL surgery, well then usually the sooner we do the ACL reconstruction in an active player, the better, because in the long run, I think it does decrease the risk of further damage.
Okay, thanks, Carl. So the next question is, do you normally consider previous injuries to decide whether to use a femoral, patella, tendon, or a hamstring?
Yeah, it certainly can come into play. I mean, if someone has had a previous patella tendon injury and so on, I might defer to the hamstrings. But I suppose here at Sports Surgery Clinic and in my own practice, we would tend to see a lot of active athletes in that age group between, I suppose, maybe 15 and 30, classically GA players, hockey players, rugby players, and so on. And for me, the patella tendon graft is the graft of choice. I mean, at the end of the day, we do see probably some increased risk of patella tendinopathy or anterior knee pain afterwards. But the bottom line is all registry data around the world has time and again shown reduced recurrence rates with the patella tendon graft. And for me, that's the graft of choice. Again, someone else asked whether or not how we handle pain in the anterior knee after BTB graft. Typically, I think that we found that people build up their strength. It really comes back to that, and proper accelerated programs where there's a lot of focus on strength work, quads work, balancing glutes and things like that, we tend to be able to overcome the pain.
Okay, thank you. So another question here is, how does knee alignment, valgus or varus, guide your decision making? And what influence does it have on your surgical management?
I suppose one of the critical factors, as I like to say, doing surface procedures, doing cartilage or osteochondral bone and cartilage procedures in isolation by just dealing with the surface will really, if you don't evaluate the alignment, it's a little like painting over rust. Valgus knee obviously will have a lot of pressure through the outer half of the knee. Similarly on a varus knee, there's a lot of pressure stresses through the inner half. So if it lies outside the normal variance, we typically will advise the patient to undergo an osteotomy at the same time. Now, that would often classically be in our older patients, maybe once they are gone beyond the very active athletic years. I am slow to undertake osteotomy work in teenagers and people in their 20s who are still involved in active sports. And in those cases, if the varus or valgus alignment is not excessive, I sometimes will consider an isolated procedure, but with the caveat for the patient that it may not resolve all their symptoms.
Okay, thank you. So the main problem physiotherapists sometimes across in Ireland sometimes find that patients with total knee replacement don't get enough information after surgery, and they're a bit lost about exercises they should do.
Yeah, I suppose that's an interesting one nowadays, and I suppose hopefully seminars like this evening will reflect the type of approach that we have at Sports Surgery Clinic, and I suppose I think a lot of my colleagues would be on the same page when we suggest that rehabilitation, I suppose, and pathways towards physiotherapy are a critical part of what we do. I think they're available both on the SSC website. They're certainly available on my own practice website. We have a physiotherapy page. We have videos. I know at the time of surgery myself, I sent all physiotherapists a report on the surgery which was done, as well as a guideline. And I think that's being followed more and more. And I certainly think that patients should be somewhat selective about maybe visiting units where that is the approach taken. The other thing I suppose we put in place recently at Sports Surgery Clinic is the concept of a discharge nurse and the availability of that person for 24/7 follow-up if issues arise, either for physiotherapists, GPs, or indeed the patients themselves.
Yeah, no, thanks. And that, Carl, thanks so much. And there's a nice comment there about you did an ACL on someone's wife, and they're just saying she's now back playing tennis and doing very well. So that's nice
great.
comment. Yeah.
Nice
so listen, thanks very much, Carl.
Thank you, Fiona, and thanks everyone for listening.
Lovely. And we're going to hand over to Katie now. And Katie is one of our lead physiotherapists, and she's going to do low back pain assessment and management. Thank you.
Hi there, you're very welcome, and firstly thank you very much for taking the time out to watch this presentation. My name is Katie Gill. I'm one of the senior physiotherapists in the Sports Surgery Clinic. Just a little bit about my background. First of all, I qualified as a physio from UCD in 2011. Following that, I worked in Dublin in private practice for a number of years before moving to London to undertake a master's in advanced neuromusculoskeletal physiotherapy. Following that, I worked in the NHS for a number of years and then moved back to Dublin to start my current role as a senior physio and PhD candidate. So I know there are going to be GPs and physios watching this presentation, so I really hope you enjoy it and I hope everybody gets something out of it. So my area of interest is in low back pain. What we're going to cover today is a little bit about the research and some challenges and the background of back pain, looking at the categories before going into assessment, treatment, exercises and the challenges that they present, as well as looking at some resources that you might be able to follow up in your own time. Now, so firstly, the categories of low back pain, start with the most straightforward part. We can really put patients into three different categories. So our non-specific, which make up 95% of cases, presenting as a first point of contact to GPs or physios, specific low back pain and red flags. So red flags, you're thinking of malignancy, so your cancers or something like quad equina, and bearing in mind that they are very rare but need to be screened. Specific low back pain makes around 5% of cases, and that is something when you can really hang your hat on the diagnosis, so be it ankylosing spondylitis or an infection like a discitis, something where you're absolutely sure you know what the diagnosis is. Now, the vast majority of our patients, as you'll see there, will be in that non-specific low back pain category. And certainly that presents a challenge because the criteria are so broad, and certainly research suggests that we can't say for certain, well, it's definitely a muscle, or it's definitely a disc, or it's your facet joint. So it's very hard to balance that with trying to meet patients' expectations, because as we all know, patients love to have a diagnosis. They love to know, is it my disc, is it my facet? So it's very difficult to be kind of honest and kind of practice in line with the evidence-based guidelines, and also trying to keep your patients happy and making sure they're with you on that journey. Excuse me. However, this is a very interesting statistic. I think 40% of people feel that they have serious spinal pathology. This was from a paper by Waddell in 2004, and I think that's quite an interesting statistic, because you think 4 out of 10 people coming into a room with back pain really think that there's something serious going on. And it's our job, I think, as physios and as GPs to kind of put those fears at bay, because as we know that 95% of them don't have something serious going on, even though they might have very severe pain. And if we think about that stat is how about 40% of people thinking there's something serious going on, and how that might impact on the patient's recovery. And it's well accepted that thoughts and feelings and beliefs can impact on how patients' pain manifests and presents. And it's also important to think of that patient's pain in terms of a context. So you might have someone on one hand who has kind of an acute episode of back pain, had something similar 10 years ago, knew he got over it in a week with some light exercise and some analgesia. So if that patient got it again, he kind of knows it's not particularly threatening as much as it's awful, it will go away. And compare and contrast that to somebody who maybe had a parent who was severely disabled with the low back pain. The first time that person gets it is going to mean something entirely different to them. So it's really important that we both legitimize patient suffering at whatever stage of their journey, as well as trying to reassure our patients every step of the way. So 2 papers I'd like to highlight were published in The Lancet about 2 years ago, and if you're not familiar with them, I'd highly recommend going to research them and have a look. They give a really good overview about the kind of epidemiology of low back pain and the evidence around treatment and assessment of low back pain as well. This slide is taken from that Lancet paper, and it really highlights that there are a number of different factors at play with low back pain, which if you like treating low back pain, it makes them really interesting, and if you don't like back pain, it can make it feel like a minefield. And there are certain tools that we'll look at later on in the presentation that can help to sort the wood from the trees. But one point I'd like to make here is that is what society thinks of back pain, and that the language we use around back pain can be quite frightening or quite powerful. And certainly the term bad back is, everybody knows somebody who has a bad back or has a disc here or something, and it's something that can be feared. And we've all attended our manual handling lectures and said, oh, we've one spine, we need to take care of it, which is true, but it also doesn't highlight the fact that the spine is a resilient structure, and that I think there's no wonder there's so much fear around back pain is when society sees this as something that is really catastrophic if something goes wrong. So as clinicians and practitioners, I guess we need to legitimize again those patients' concerns while giving the right information at the right time. So in terms of the presentation, it's hugely varied. It can affect anybody at any point of their lives. So yes, it can be high prevalence of manual workers, people who are active can suffer from back pain, sedentary workers can suffer from back pain. So it really does depend, and can make it both very interesting to treat. But what can be really common is what this pain cycle. So going from pain into guarding, into your muscle spasm, leading into restricted mobility. And I'm sure you will agree that lots of our patients will fit into this pain cycle when they come to see us. But it's also to remember that that is also completely normal. Is that someone, say 2 days into kind of a severe flare of their back pain, you know, of course they're going to be annoyed that they can't take place in their sporting event, or they can't lift their child up. And that is adaptive, that is okay. But if you have that on, you know, 6 months in, and you're still feeling angry and frustrated, and you still have a loss of normal function, and that is when those behaviors are not helpful. So where we both as GPs and physios want to bring people from that deconditioning cycle, you can see there at the bottom, and then bring them into this reconditioning cycle, and we can do that by education and by exercise, and by guiding patients along that journey. So why do we care? Why do we care so much that we keep our patients active and that we don't promote bed rest? So I'll talk to you through a few of these bubbles. So reduced bone mineral density. Obviously, we all know the importance of maintaining healthy bones. And obviously, if we're not loading our system and if we're remaining inactive, it can have an impact long term on our bone mineral density. Increased fear of movement and rewarding bad behavior kind of link in together. And I'd often try to explain to my patients that if you have a learned response, if you lift and you get a pain, of course you're going to learn that lifting or think that lifting is bad. But we have to tie our shoes. We have to kind of pick things up. That is part of normal life, and it's important that we maintain good spinal mobility. But what we don't want to do is every time we bend think that's bad and tense up. And if we shy away from all of those things, it's rewarding bad behavior, saying, okay, well, I've learned that that's bad. I'm going to, you know, reward it by avoiding it. And we can get back into that cycle that we saw in the previous slide, that the less we do, the less we do, the less we do, the less we do. If we're not kind of moving and loading optimally, you'll reduce muscle strength. We'll lose cardiovascular fitness, and the one I want to highlight here is increasing fatty infiltrates. So we've all heard of the expression, if you don't use it, you lose it. Take that one step further, if you don't use it, it becomes filled with fat. So muscle tissue, if it's not loaded and if it's not used, those muscle fibers waste away, and not only do they waste away, but they're replaced by fat. So if we look at this kind of cross-section MRI, and going from left to right, you can see erector spinae there with no fatty infiltrates, with some in the middle, and then with greater than 50%. And if you think of that section as just being an inefficient, if your muscles have that much fat in them, they're not going to be able to move optimally, even from day-to-day tasks to kind of picking things up and moving around. So what does the evidence show? What can we do, and what can we treat? So I think it can be useful to divide them up like a traffic light system. So what can we directly target? What might we be able to target, and what is the potential barrier? So research suggests, though, the things that we can look at that have an impact on low back pain, you can see there. So lower activity levels, alteration in muscle size, composition and coordination, so muscles including the gluteals, the erector spinae, your abdominal muscles. So we're not just focused on one muscle group, but you need good function and good strength across the muscle groups in the lower quadrant for normal functioning. Increased fatty infiltrates. There's been a huge amount of research for people with back pain that they get these increased fatty infiltrates in the muscles, and in terms of increased fear avoidance. So we know that we can direct targets to treat those. Moving on, so things like higher levels of anxiety, depression these are all things that are noted in people with lower back pain. Poor sleep, you could argue that you increase activity levels, you might have an impact on sleep. If someone is a chronically poor sleeper, you know, I don't think it's reasonable to set a target to change that. Poor motivation, maybe that will change, maybe it won't. So those things will depend really on the context and on the patient. The one thing we can't do anything about is the higher prevalence in the lower socioeconomic groups, lower education or low health literacy. So moving on to the assessment. So what are the priorities of the initial one? So firstly, we're going to screen for red flags, and then clarify lumbar as a source of symptoms. So the hip can often present, or patients might have kind of diffuse pain across the lower back or across their hip, and you're wondering, is it one or is it both? So if we're giving back pain advice, we need to make sure that it is their back that's causing their symptoms. Looking, as we talked about earlier, the importance of having a clear target for your treatment and seeing what contributing factors, if any, are at play. big one is legitimizing patients' concerns and following up and reassuring your patient, and looking to start evidence-based treatment. So one question I want to throw out is do you ever give patients forms to fill in before they enter the room? More from a GP point of view, because your time is much shorter than ours as physios. And I would encourage you to try maybe leave some of these, a body chart, in the waiting room, and with the sign saying if you've got back pain, just shade in the area or say where your pins and needles or numbness are, because it helps you to focus in it. Within 2 seconds you'll know, okay, it's back pain, or is it also back pain and radiculopathy, which means I need to maybe think about doing a neuro exam, and I need to budget time for that. So it is something that might be worth trialing. The other thing that can be worth putting with that body chart is the Start Back tool. Now, I have the reference linked later on. So this comes out of Keele University, who do a huge amount of research with both low back and things like knee osteoarthritis. And getting patients to fill this in takes 2 or 3 seconds to do, and you divide them into 3 categories. So you've got your low risk, medium risk, and high risk. Patients with low risk generally do well with things like advice and education. If you have a booklet in the clinic, that can work well too. Medium risk, you might want to consider referring to physiotherapy then, or maybe rebooking if your GP say, look, I'll definitely follow you up in 2 to 3 weeks time. And high risk, you might think, I'm going to refer to physio who is comfortable with treating patients with more persistent pain problems, or you might be thinking about, I need to get psychology involved. And it just gets the patient, matches the patient to the treatment as quickly as we can. From a physiotherapy perspective, depending on where you're working, if you take a look at questions 5, maybe in question 7, we're starting to use these almost as a springboard for discussion. So it's not really safe for a patient, for a person in my condition, to be physically active. I mean, 9 times out of 10 as a physio, you're going to give somebody some advice or exercises to do, and that's a lovely springboard into saying, well, are there going to be any barriers to the treatment I give them? So I'm not going to discuss the red flags in too much detail, because kind of conversation for another day. If anybody has questions, they can flag this at the end, but just having this in it for completeness. The key areas of the subjective exam, so looking at the history and looking at the mechanism. So was there a trauma? Is there a history of osteoporosis? And looking at the body chart that I had earlier on. So this is important in lots of different areas for lots of different reasons. So as I mentioned earlier on, if someone has a radicular pain or radiculopathy, you might get a better idea of what level that could be at. From a physio perspective, you'll get loads of information about whether that's progressing or regressing, depending on where the pins and needles are, or if they're pins and needles, or the first time you saw them they pins and needles and now they have kind of myotomal loss. So getting loads of information there can help with diagnosis and help look at progressions and regressions. It also can be helpful in terms of looking at if someone has a persistent pain dysfunction, and really shows that listening skill that you can say, okay, I want to know about someone who's seen loads of different healthcare professionals and think, okay, I'm going to use this as a tool because I want to know exactly what your suffering is and what your pain is, and to feed all of that back to the patient can be quite useful. Axonesis, so what makes it better, what makes it worse, and how long that takes, can give a really good idea for how irritable the patient is. And the final thing is looking at identifying worries and concerns. Now, they're probably the key areas from a GP perspective. When you have less time, physios might be able to expand a little bit more. But the one thing to look at is making sure that you ask every patient with back pain if they have concerns or if they're worried, because remember that statistic from earlier on, 4 out of 10 people are going to think there's something really wrong with them. And considering back pain is so severe and so painful, it's completely understandable. In one patient, having a very brief conversation saying, well, actually, in 6 weeks, we know that the vast majority of patients get better, and with simple advice will be enough to reassure somebody. Other people, it won't be enough, and you need to spend more of your treatment time focusing on that. But if we don't ask, we don't necessarily know the answer. So looking at the key areas, so active range of motion. So what you're looking at there is how much they move. There's no gold standards. You need to move. You need to be able to touch your toes. For good function, you really need to be able to clear your hands below your knees. But the main thing here is looking at how they move. Do they move freely? Do they hold their back? Do they lean forward and then walk their hands upwards to use their hands as some support? And is that adaptive or maladaptive? 2 days in, someone's kind of gets stuck down and trying to push themselves back up again. That makes sense. Someone is still doing that 6 months in. It's something I would highlight to your patient as they do it, and then talk about at the end of the session. So something functional, something quick, is putting something on the floor. So don't think about it too much. Just go over and pick that up. You could ask someone to take something on and off your shelf, and just kind of screen how they move in a more kind of normal way. Other things like squat or single leg squat or walking are also helpful. The neurological exam, if you need to, neural provocation can help. If you're in between whether there is neurology involved, you can add those in. And then just looking at screening the hip and sacroiliac joint if needed. So you'll get a lot of information about that subjectively in terms of your ags and eases, where the pain actually is, and things like their age and previous history can help, but matched with things like quadrant, their passive range and functional tests can help to determine whether it's and or. So moving into treatment, this slide was taken from, or this graph was taken from that paper I referenced earlier in the Lancet, so published 2 years ago, and it divides pain into before 6 weeks or after 6 weeks. So we'll focus on the acute back pain for the moment. So what we need to do, as you can see there, is our advice and education is of key importance, and that there's insufficient evidence for any sort of specific exercise therapy. So it's just really key that there isn't anything that we're supposed to do more really from a physiotherapy perspective. The only advice they give us is just to keep active and keep moving. And then spine manipulation may or may not be helpful depending on your patient, and same with things like yoga and acupuncture. So recap on the early management in the acute phase below level of 6 weeks is your advice, reassurance, so reassuring that most cases settle within 6 weeks, to make sure you keep moving and make sure there's no bed rest, and things like hurt doesn't mean it's harm, and you're sore but safe, and just telling them, well, yeah, absolutely, your back is very, very sore, but that doesn't mean there's anything damaging going on. If we look at the persistence, so at what happens after 12 weeks, so the green box highlights really what is the first line of treatment. So again, the advice to remain active, looking at education, and an exercise therapy. Again, we're going to talk about the limitations of these guidelines in a moment. CBT you can consider for first-line treatment for routine use, but again, will depend on the patient. And the things that are second on or adjunctive are spinal manips, massage, acupuncture, and things like mindfulness-based stress techniques. So those are things that are not as important as the advice and things that we give. And I think with those, you're just going to pick and choose depending on the patient's presentation. So with the guidelines provide an overview, but the best guideline we have for the moment in terms of what we should be doing comes from the American College of Sports Medicine, which looks at being active for 150 minutes per week of moderate intensity activity or 75 vigorous minutes. And what we're supposed to be doing anyway is 2 episodes of strength and 1 episode of balance. Nothing to do with back pain. That is what we all should be doing and promoting with our patients anyway. So the limitation of the guidelines. So it just it doesn't really give a clear indication of what we should do, and it also sets the bar very low. So for some patients, giving them the advice that just do something. For some patients that's enough, and that is the right thing to say, but just doing something is very broad, and it doesn't tell us, should we be doing yoga or Pilates or going to the gym or walking. And certainly there's no research that suggests that any one of those modalities is any better than the other. It also gives us no advice about things like sets and reps for training, and I think there's a real gap in our gap there, and it kind of allows us to kind of set the bar in a way quite low for our patients, and then all we have really to fall back on is the guidelines of the American College of Sports Medicine, which also highlight that we should be doing 2 episodes of resistance training anyway. So if that's what we can't do, what do we do? So remembering that what are our targets, what are patients coming in with? So they'll often have lower general activity levels, again looking at alteration of muscle size, composition and coordination, and are looking at those fatty infiltrates. And one of the things around training is that sometimes patients will say, well, I go to my one class a week, and I think no matter what class you're doing something once a week is not going to change your fatty infiltrates. It's not going to reach the recommended guidelines of doing something twice a week. So I think just being mindful of that sometimes that we don't set that bar too low. So having a look at some research that did look at resistance training, and it showed that with regular resistance training that the percentage of lumbar fatty infiltrates reduced with regular training, which is incredible to know, because we know that that is something that is prevalent in the population. Being careful though that we don't kind of go down too much on the biopsychosocial model. We need to fit that into the patient's own goals, of course, and what they want to get out of their treatment. But it's just to highlight that this is a safe and safe way to train and can target one of the impairments that we mentioned earlier on. So what is the model of care that we employ in the sports surgery clinic? So as best we can, we try to work under a biopsychosocial model of care. So identifying any structural factors. So is it a low exercise tolerance? Is there a kind of weakness around the hip that's impeding on function? Is there a loss of strength? Do we have MRI evidence that there might be fatty infiltrates in the muscle, or just someone who is not meeting recommended exercise guidelines? And teaming those with the psychological factors. I mean, are there unhelpful beliefs or inaccurate information around back pain that we need to talk through? Do we need to talk about stress management, or looking at doing some mindfulness-based therapies, as well as some other factors, and then social factors where it's obviously appropriate to delve into. Just being mindful that there can often be more going on for patients, and just to acknowledge and discuss any contributing factors that are relevant. So the model of care, again, in sports surgery clinic, our reminder of our referral sources to physiotherapy. We have our own consultants here in sports medicine who refer patients in. We have orthopaedics in sports surgery as well, who will refer patients post-discectomy or like post-lumbar fusion. We also have pain management who refer often post-injection. Looking at staffing, so we have a team here who see lots of lumbar patients, including strength and conditioning coaches and physios. Just a note about the back class, this runs kind of morning, afternoon and evening, and patients will often attend 3 sessions a week. They do a warm-up all together. There's max 6 in a group, and it's run or supervised by one of the strength and conditioning coaches or myself. And in that class, for those who are not maybe used to the setup here, is that we would have patients maybe one day doing their deadlift, doing some abdominal exercises, doing some upper body work, and another day they might do their front squat, they might do some hip thrusting, and all done with resistance training, because what we looked at earlier, if we can't change those fatty infiltrates if we're doing something once a week, if we're not, we need to target those with resistance training, and that model of care we find works really, really well and is supported by research. So I'll just put that in terms if you have any questions or any referrals that you want to send in. The take-home message, obviously important to outrule red flags, encouraging movement at all stages of recovery, looking at positive language, thinking about is imaging going to change management, and just remembering that the back is resilient, and getting that balance of legitimizing a concern as well as giving the correct education at the right time is important. A few resources that you can maybe screen grab. So this is a very useful table that I'd often have at hand. So I'm sure we've all had patients who have come in with an MRI or have been told they have problems with their disc or they have a protrusion. And it can be really helpful to firstly legitimize and say, absolutely, we know you have back pain, but to show them this table which shows the age-specific findings in asymptomatic patients. And it can be really helpful for patients to see, well, actually, do you know what, from the age of and 30 on, about 50% or 52% of patients have disc degeneration, and that they don't have pain. And it can be a hugely powerful tool to kind of de-threaten and to make those findings normal. So it's something, if you screen grab that, or I can send you on the paper and have that diagram close to hand, can be quite helpful. Another just infographic, if you wanted to print them out for your clinics, about the amount of exercise we're supposed to do. Same there again. Start back training and Keil, I mentioned it earlier on. If you're not familiar with them, they produce fantastic research. There's an online training that you can do. It takes an hour and a half to 2 to complete, and there's a huge amount of resources there. There's a patient pacing or a patient pain app in terms of monitoring their symptoms, which I've put down here. So there's a few resources there for patients who might be a bit more challenging, and to send them away with something to look at, so they're hearing the information around pain and education from another voice. So thank you again very much for taking the time to listen to the presentation, and we'll take some questions now whenever, if you would like.
Hi Katie, thank you very much for that great presentation.
Thank you.
Somebody did ask for some reference links, so we're going to send those out. Okay, so they're already being sent out to that person. So the first question is regarding exercises. I often prescribe twice a day. Is that wrong?
So the answer is not necessarily, and I think we won't have time to go through all the questions, but one thing that will link into that is the fatty infiltrates. So somebody also asked whether there's a correlation between pain and fatty infiltrates, so we'll answer that in one.
Yeah.
So again, as we looked at, there is no clear guidance on what we should or shouldn't do. But what we need to try to remember is as physios, is what target, when we say we're strengthening a patient, what we're doing is providing a program that's based in muscle physiology. So I think sometimes we'll give exercise twice a day, every day, and we're wondering why in the name of goodness patients aren't doing them. And even if they are, on a cellular level, what are we actually trying to do? Whereas often people who are exercising and strengthening for good health will go to the gym 2 or 3 times a week, and that is how they will overload their system. And effectively your back muscles and your abdominal muscles and your hip muscles, they don't care that you've got back pain. Their muscle physiology will respond to strengthening in the same way. So I would just kind of challenge the thinking around doing kind of more exercises more frequently, or doing more challenging exercises less frequently. However, if you're thinking, well, actually my patient just needs to get up and move a little bit more, if that is your justification and your rationale, then that's fine. But I probably sooner tell them to go out and go for a walk or do something different.
Yeah.
And with regards to the fatty infiltrates, no, there is no correlation. And I think it's a very important point to come across, because if people remember 10 years ago in the literature about trans ab, and that we all were so excited for a while that, people had low trans ab activation, and we were doing so many trans ab exercises. So I want to be very careful that there's no correlation with pain. It's just something that is been found in patients with low back pain, and it seems to me at least sensible that that's something that we might target, and it just shows that there's impaired function.
Okay, thanks Katie. Now, next question is, if a patient has fear of bending, what cues exercise do you find useful to gradually expose them to movement?
Okay, and it's a really good question. I think sometimes I wouldn't necessarily use exercise, because if you just tell someone to do something that they're afraid of, what response are you really expecting? Someone also in another question mentioned about breathing, and this is sometimes where I would use breathing and trying to get the nervous system to settle down a little bit. So first of all, I think before even having that conversation, I'd look about the movement that they're afraid of and why. Sometimes you can ask a patient, I'm sure we'll all have someone in mind, to lean forward and see how far they can touch their toes, and they won't be able to do it. You ask them to do the same thing in sitting, they actually have a lovely curve in their back. So I'd often say, okay, what's the difference there? And I'd often say, okay, well, look, your back looks like a lovely rainbow. How come you can't do that standing? Or use the patient's own phone and video them doing certain movements, and they have no idea often that their movement is so poor in certain areas. So I think giving them a feedback and showing them either with their phone or saying, well, actually, this is what it looks like, and you don't need to move in this way, can be a good step. Other things I think is just going slowly and reminding your patient, saying, well, look, I won't give you something that's going to damage you, and you take the onus of responsibility back onto yourself and say, look, this is all very straightforward, and yes, you might have some pain with it. And the fact that you've predicted that, you've said, okay, maybe if it might be sore, it might not be, but they know that that's a potential option. But it's also, even though they're sore, they're not going to be damaging. So things like the camera, things like pelvic rolls, and moving a body part really nice and slowly, or using some deep breathing can really, really help.
Okay, brilliant. So now, Katie, there's two people who have mentioned the Start Back tool. So yeah. I'm just going to let you have a talk about that.
Of course. I think one was looking about whether we would use it in public or private settings.
Yeah.
And they worked in the NHS as well. So yes, it is was kind of tested in the NHS and has been a huge cost-saving measure. Now, to the best of my knowledge, and don't quote me on it, I don't work in Beaumont. I think that they use it there to triage. As for other private practices or other hospitals, I can't comment. It's something that we're looking to use in sports surgery in the outpatient setting a little bit more. Even just as for me, it's that question 5 is to use that as a springboard. And I think someone else was looking at, do we use that as a screening tool to get into the class? So there's no kind of criteria in terms of you have to have this, you have to have done the rotamoris, or you have to do osmosphere or Orbrio. For our back classes, we just have someone who's not in acute back pain, that their pain is settled. And we're looking at changing the outcome measures we use in the clinic at the moment. It's actually part of my PhD, so I don't want to comment and say this is exactly what we're using. But we're looking at some outcome measures that you might have a look at are the MSK-HQ. That is one that I think is going to be coming up because it is valid for back pain and neck pain and knee pain. So that might be one to look at as well.
Okay, thanks for the last question.
Sure.
Someone says, thanks for the great lecture. Despite the limited evidence, acute low back pain, do you prescribe a home exercise program for your patients or focused on generalized physical activity?
Really good question. I think it's the question is, do you practice what you preach? And I think with and I think I do and I don't. I think it depends on the patient that's there in front of me. I think my first bit is being honest with the advice and evidence that I give, that we spoke about earlier on, and saying that this is your movement, this is what you're going at. But I think if it would depend on what their specific goals are, and if you're kind of testing around hip musculature and they're going to be a hill walker, or they are a hill walker, and you kind of think, well, I think where I'm comfortable practicing is like, look, your pain will more than likely settle itself. However, I've noticed actually that for your level of physical activity or what you want to get out of, those hips aren't strong enough, and you would probably benefit by doing some of these exercises. But where I feel very strongly is the sell is on their function and not on their pain, and to say that you are doing this for your task and your goal. You are not doing this because your back is sore. These are just incidental findings, but while you're here, let's get you stronger and better able to walk up the hill. So I think I would, if there's something going on, I think if someone was potentially particularly anxious, and I'd often you almost want to tell them, look, go out and potter around the house and do what you need to do. I'd often say to them, I'd only love to give you some exercises to do. I'd only love to get things, but I really think in your case, unless there's something specific you want to work on, I think you're better off, going for your walks or following this advice. And here's I think it depends.
Yeah, no, that's brilliant. Listen, thanks so much for that, Katie.
Thank you very much. Thanks for listening.
You're welcome. So now we have Miss Anne-Maria Byrne, and Anne-Maria is an orthopaedic surgeon at Sports Surgery Clinic, and she specialises in upper limb, and she's going to be talking about tendinopathy about the elbow. Thank you.
Thank you. In my role as an elbow, wrist and hand specialist in Sports Surgery Clinic, we are seeing a tsunami of problems related to tendinopathy around the elbow. The common problems that present to my practice, and specifically to my elbow practice, you can see that there are 3 tendinopathies in the top 6 conditions. So tennis elbow, golfer's elbow, and then the distal biceps, either being tendinopathy and rupture. The fourth one of those being the triceps, not seeing so much of, but it's becoming more and more common. And I think that's related to use of anabolic steroids. But what I'm seeing huge numbers of, and I'm sure that in primary care, their patients are coming from there as well, is tennis elbow, also known as lateral epicondylitis. So it's been around for a long time. It was Morris who published about it in the Lancet in the 1880s, who described it as lawn tennis elbow. And it is thought that between 40 and 50% of all tennis players will experience an episode of tennis elbow at some stage in their career. It's related to resisted wrist extension while playing racket sports, and that's typically seen while doing a backhand. I also see it in patients who have poor technique, where they've perhaps changed their grip, they've changed their string tension because they want to get a bit of top spin, and as a result of that are causing extra forces to go up into the lateral side of the elbow, causing the problems. Then there's a group of patients who have shoulder or wrist injuries, and as a result, they're putting extra pressure on the elbow and develop symptoms with that. However, I'd say less than 5% of my patients actually play tennis who present with these symptoms. And we can see that things have changed very much in how we use our elbows. In the past, the elbow was used for basically feeding ourselves, washing ourselves, and shooting spears, whereas now we're using it for tools, for typing, for we're crouched in positions that we shouldn't be in for long periods of time, and then we're heading off to the gym or doing DIY, and that kicks off a lot of our symptoms. Now, at the moment, it has been reported that we're seeing between 1 and 3% per year of lateral epicondylitis or tennis elbow. So they are huge numbers that are seen. It usually affects the dominant arm, but I find it doesn't make a huge amount of difference. It can affect either arm. About 7% of patients, it's occupationally related. But again, I see it in patients that can range from chefs to carpenters, to people who are at computers for long periods of time and then going off and doing kettlebells or stretches, quickly in the evening, or going and playing the odd game of golf in the evening, and that kicks off their symptoms. The one thing that seems to be throughout all of the cases is that it's repetitive wrist motion with extension and gripping. The exact cause of the symptoms are unknown. However, we do know that it affects mainly the extensor carpi radialis brevis tendon, or the ERCB. And it is thought that this is a mechanically induced condition related to the shearing forces with various elbow motions, particularly with these repetitive motions. So the most important thing I've said there is that this is a degenerative tendon. A lot of patients are coming in thinking that they have inflammation, and this is what's causing it. Their elbow is inflamed, but it is not. It is a degenerative condition, and it usually comes on over time. They may be presenting with this one episode, however, it's built up with time. So it's never just one thing that kicks it off. What's interesting about it when you look at the tendon tissue under a microscope is that it shows this angiofibroblastic dysplasia. And what this is that the tendon is trying to repair itself and heal itself with fibroblasts, and it's bringing in extra blood vessels, but there is poor blood supply even though there are more blood vessels, because the blood vessels themselves don't have appropriate lumens and they're bringing less blood. So as a result of this, it is a degenerative tendon condition and not fitting into the inflammatory category, and that is something that we have to educate our patients about. They present with lateral sided elbow pain. They localize it to the lateral epicondyle of the elbow where the tendon actually inserts. They describe very classic symptoms where the pain is worse with the wrist in extension. They often describe pain with shaking hands, making a fist, lifting things, and particularly you'll see that people have difficulty lifting a kettle, pots and pans, chopping vegetables, basic day-to-day living, as well as the work environment and sports and things like that. Some people would describe kind of radiating pain into their forearm and into their upper arm, and this is thought to be related to lactic acid buildup in the muscle rather than any nerve kind of symptoms. But sometimes patients describe it as being like nerve pain, but it's more radicular symptoms into the muscle. Some people will describe swelling on the lateral side of their elbow, and I think they're probably the patients who are a little bit worse, and this comes and goes. Often when they come in and see me, they don't have it. It's not there. It's always when you come and see the doctor, you don't have the worst symptoms. But if they describe it, I know their symptoms probably have been more prolonged and have been more severe. There are various tests. The tests that I use most commonly are the Cosen's tests and the Maudsley tests. So the Cosen's test is where you get the patient to extend their wrist against your own hand, so they have a bit of resistance, and they will describe pain on the lateral side of their elbow. And I do this with the patient's arm in 30 degrees of flexion and in full extension. A lot of times patients will say their symptoms are worse in full extension. The Maudsley's test is where you have resisted extension of the middle finger, and that is where the tendon, ERCB tendon, actually inserts. And again, I do this in flexion and extension. And again, a lot of the time the patients will say they feel worse when they're in extension. There are other tests, but they're the ones that I use most commonly in my practice, and I get the best results from those. And the patients are very typically sore right over that lateral epicondyle when you press on that. The diagnosis is often a clinical diagnosis where they describe the symptoms, and on examination they present with the symptoms and the signs of tennis elbow. However, when they come to me, they've usually gone through various other treatment regimes, so I always get an MRI scan, and it's to outrule any underlying pathology such as arthritis or a plica of synovium, which is mimicking the symptoms of tennis elbow. In some patients who have swelling, you might see a rupture of the capsule or a ganglion, and then in other patients there might be a suggestion that they had an old injury or a fracture, and they may have some instability of the ligaments on that side, which is mimicking tennis elbow. So that's why I get an MRI scan, is just to make sure that the diagnosis is correct and that my proceeding with treatment is correct. In the image that we have there, you can see very nicely where the tendon is lifting away from the bone with the arrows, and you can see the white area of enhanced signal in the area on the lateral side of the elbow. Obviously, when the patient comes in, presents with all of these, again, when I see them, they've usually gone through some kind of a treatment regime with their GP or their physiotherapist. And of course, Dr. Google has helped them as well, so they've probably done a good bit of research themselves. The first thing that I have to do is to temper their expectations, because when they come into me, they want a quick fix. They've had a friend who's had an injection and it cured everything, and they were back playing sport or doing their DIY and gardening the next week. And unfortunately, with this kind of degenerative condition, that's just not the case. So the first thing that I have to counsel them about is that this is going to take time. And the first thing that they're going to have to do is rest and use activity modification. And that breaks their hearts, particularly with the keen amateur sports people who have a lot invested in their league tennis or their competitive golf. So that's the first thing, is to get them around to their way of thinking with regards to the activity modification. In terms of anti-inflammatories, either orally or topically, research has shown that they can help. It's not an inflammatory condition, as we said, but it certainly can take the edge off in terms of pain in somebody who's having an acute event. And that, along with rest and ice, certainly is the first line for somebody who's an acute event presentation. The next thing that's been shown to make the biggest difference is an isokinetic eccentric exercise program. And I give patients either a copy of a program to do, which starts off with stretches and no weights, and then builds up through the weeks to putting in weights for strength and conditioning. And this has been proven to be the most effective way of long-term treating lateral epicondylitis conservatively. In terms of time putting into this, in terms of recovery, the patients do need to commit to the exercise program for up to 3 months, because there is no quick fix with this, unfortunately. If a patient has severe pain, an option is local anesthetic and steroid injection. there has been quite a lot of debate in the literature about, you know, potential damage to tendons and cartilage and joint injections and things like that. And that is a real issue with steroid injections, and we have to take that on board. There is a use for these steroid injections for acute pain relief in the patient who is really suffering and in agony and actually can't do any exercises, can't sleep at night, can't straighten out their arm. So a steroid injection will help give them pain relief, but only so that they can continue on with their rehabilitation. This is not the cure. This is just to dampen down the symptoms so they can get on with their other rehabilitation. The patients have to be consented with regards to issues such as thinning of the skin, discoloration of the skin, fat necrosis, and I would only ever do a maximum of 3 injections due to potential side effects. And that is something, again, that the patients need to realise, because there are patients who will ring up looking for a quick fix of an injection because they've got a competitive golf game coming up in the next week, and unfortunately that is not a good indication for that kind of treatment. The other thing that is coming to the fore on the conservative side of things are PRP injections, and these are platelet-rich plasma injections, which are injected into the area and excite an inflammatory reaction with lots of good cytokines, growth factors that attempt to help the tendon to heal. Recently, Watts et al. Have published a study showing good results with PRP injections for tennis elbow, and have suggested that they avoided progression to surgery in 70% of their patients using these PRP injections, which is a great option to avoid surgery in a lot of patients. And I work closely with the sports medicine department in the sports surgery clinic, and they will do those for me. I also suggest use of a counterforce tennis elbow brace, and there's just an image of it there. And what this is it dissipates the stresses coming from the wrist into the muscles of the forearm. The muscles can take that. It takes away the stresses from the lateral side of the elbow, which allows your symptom to settle down and heal. And patients do find that very useful. I use it in this position for the tennis elbow, and you can flip the pressure point around the other way for golfer's elbow. And I find that that does help. It is not a support brace, however, it is a counterforce brace. It stops the forces going to the outside of the elbow, and they are useful once they are used appropriately with activity. And there's just an image there as well to show you just the eccentric stretching of the forearm to stretch out the muscle. And I definitely think there is a link between sitting at computers, typing for long periods of time, all of the muscles in the forearm tightening up, and then going to do stretches or gym work or cycling or whatever, and then putting excess pressure in this watershed, poor blood supply area of the lateral tendon, and this causes the micro tears and degeneration in the tendon. So I often will ask my patients, if they're sitting at a computer for 10 hours a day, to do stretches on a regular basis throughout the day so that their muscles in the forearm aren't all tightening up. The steroid injections are localized to the lateral side of the elbow. I always go slightly anteriorly to avoid any damage to the ligaments, which are more posterior on the lateral side of the elbow. And I inject slightly proximally to the tendon also, and I will go in and out with the needle to give me nearly a dry needling effect as I'm injecting in the steroid into the area, just to make sure that it's actually getting to where it needs to go. The image below it is just of the platelet-rich plasma. So what happens there is you take a sample of the patient's blood, spin it down in a centrifuge, and separate out the various constituent parts of the plasma. And it's the platelet-rich plasma area that's the important aspect for injecting into this. It's a completely different idea to the steroid injection. The steroid is purely for pain relief. The PRP injections will cause quite a lot of painful symptoms for the patients, but the idea is that they have more long-term relief of this, in that they're trying to get the tendon to heal long-term. In terms of the most severe cases, and for me, this is now probably about 5% of the patients that present to me who don't settle down. And these may be the people who are carpenters, who are, very active and have tried everything and have gone through a full 6 months of good quality rehabilitation. They're not sleeping at night, they're not able to continue on with their sport or their work. These are the patients that I would consider for actual surgery. In terms of tears, sometimes the people who have smaller tears are more symptomatic with pain than people who have larger tears, and it may be that the area just decompressed with the larger tears. It's difficult to say. Research hasn't been done in that area. However, the patients that I would consider for surgery are those who have proceeded to fail their conservative treatment. What I do is a day case operation under general anaesthetic, where I make an incision on the lateral side of the elbow. I split the tendon and I debride away any areas of damaged or dead tendon. I then drill a suture anchor into the bone, and I think that works in several ways, because I can use the sutures to reattach to the tendon to the prepared bone, and also by drilling the bone you also release all the good quality growth factors, cytokines and all of those again from the area of the lateral epicondyle in and around the tendon, and it helps the tendon to heal and stick down in that area. And I find that the patients do very well quite quickly, and they feel they get their strength back. But again, further research needs to be done on this in terms of randomized controlled trials. But this is a similar technique used by various elbow surgeons around the world with good results. Other arthroscopic procedures are useful for patients who have other joint pathology or who have plicas on their MRI scan, and that can be used as well. But my first go-to will be the mini open procedure with a suture anchor, because the patients do so well with that. And I find that they certainly get back to sports, within 3 to 6 months after this type of surgery. And I'm getting an over 90% success rate, which is I'm happy with that, and the patients are happy with that. In terms of the medial side of the joint, or golfer's elbow, it is a different type of disease, and certainly we're seeing between 7 and 20 times in the literature less likely, and I'd certainly say in my experience it's more than 20 times less common than tennis elbow. Tennis elbow is so common, whereas golfer's elbow is certainly rarer. It's a different type of disease in that it is not related to purely degeneration of the tendon. It's more of a tendinosis of the whole flexor pronator mass, and it's actually seen more commonly in tennis players, in athletes who use overhead throwing. You find that they're overtraining or they've poor techniques, and I see it in groups of people like javelin throwers, in cricketers, tennis players, and other groups who might be using valgus strain to their elbow. You have to outrule that they may have other problems on the medial side of their elbow. Again, arthritis type problems, ulnar collateral ligament instability, or an ulnar nerve problem or neuritis. And you can see those with impingement type pictures with cricketers, and we don't see baseball players, but it'd be certainly very common in the United States, where there'll be a lot of baseball players. In terms of occupational settings, I think it's probably less prevalent than tennis elbow, but the literature is saying that they see, about 8% of their patients, their problems come from their occupational settings. There doesn't seem to be a huge difference between male and females, and they've reported various age groups between 40 and 60. So we're not seeing either of these problems in patients in their 20s to 30s. It's in the older, middle-aged groups that we're seeing these problems. For the medial sided symptoms, the patients are getting issues with repetitive flexion of their wrist and pronation of their forearm. And again, because of the overhead throwing, you see it with valgus overload. So it's a specific technique issue with overhead throwing athletes who get these kind of medial sided pain and problems. So on these images, you can see the golfer's elbow very much isolated to this medial side. And remember that just deep to the medial epicondyle is the medial collateral ligament or ulnar collateral ligament. And you have to outrule any issues with instability in that when you're examining your patient as well, as they can be associated certainly in the throwing athletes. The treatment options for golfer's elbow, just like tennis elbow, the first role is rehabilitation. Patients start off with their passive stretches. They may find the eccentric program a little bit difficult and actually exacerbate their symptoms on the medial side. So it's open chain, passive exercises. And in throwing athletes, it's very important to look at any issues with the shoulder, such as shoulder dyskinesia or an undiagnosed shoulder issue, because if there's a problem there, they're then putting excess pressure on the elbow. Patients also need to work on their core stability, because any issues there or back problems will cause problems with excess pressure on the elbow. Later on, as they build up their confidence and their pain is improved, they can go on to concentric and loading exercises to the medial side of the elbow, and then work on power, but that can take many months to be able to build up the power. You can work on pain relief and then stretches first, and then only later on, once the symptoms are under control, can you build up your strength and conditioning and power. As I mentioned before, I use the counterforce braces or the tennis elbow braces again. For golfer's elbow, I just flip the pressure point around and put it on the flexor pronator mass, and that is very helpful with symptoms there. Steroid injections, as before, are purely for symptomatic relief, and PRP injections have been used and described. These steroid injections and PRP seem to be less successful on the medial side of the elbow. We're not entirely sure why that is, but they can have a role in symptomatic control. But the main stay of treatment is rehabilitation. Again, surgical options, failed conservative treatment for the medial side of the elbow. Again, surgical treatment is less successful than for tennis elbow, and you must address potential other issues, such as ulnar nerve issues, whether that just be ulnar nerve compression, subluxation of the ulnar nerve, or an ulnar nerve neuritis due to impingement issues. You have to check for your ulnar collateral ligament issues, where there's potential instability of the elbow, which is causing problems on the medial side of the elbow. There are various operations for this. Usually I just do a simple release, and I will always release the ulnar nerve at the same time, and this usually addresses both potential problems on that side. My aim with patients is a return to sport between 3 and 6 months. It completely depends on what their sports is. So you'll see people who are returning to golf and tennis will get back much faster than people who are javelin throwers and such like. So it very much depends on the rehabilitation after surgery of what the sports the patient actually partakes in. Now, of course, the most important thing in all epicondylitis issues is that they are preventable. So to prevent these, when you're playing your golf and your tennis, the warm-up stretches are the most important thing. I'm not a good golfer. I will still do my stretches between every hole just to make sure I don't get any problem with epicondylitis. Look at your technique, honestly, and make sure that if it needs modification, that you can work on that. Tennis rackets, racket sports, badminton, squash, you may need to change your grip size so you're not gripping too tightly, which causes problems with epicondylitis. And then obviously for the golfers, to avoid doing things like hitting the ground. So good technique, warm-up stretches, and prevention is better than cure. Thank you.
Thank you, Anne-Maria. That was very informative. So the first question is, how do you differentiate between tennis elbow and radial tunnel syndrome?
It's a very good question, because by the time patients come to me, I have to outrule a lot of differential diagnosis because they've been treated elsewhere. So the tennis elbow, if you palpate just at the lateral epicondyle, they'll have specific pain there. And then I do my Cosen's and Mills and Maudslay's tests, where I stress the middle finger and the wrist in extension. And I do that in flexion and full extension. And some patients will say it's worse in extension. So that very specifically is tennis elbow. Right. The radial tunnel syndrome is a lot less specific. The pain will be more distal to the lateral epicondyle, and they may complain of a burning pain that's going down into the forearm. Now, you can also get that with tennis tennis elbow and they think it's related to, ischemic kind of changes in the muscle. But if you press down on the mobile WOD area for a period of 30 seconds, the patients will say that they can get this burning sensation in their forearm, and that's the radial tunnel syndrome. It's also the type of patient, when you see them where they are rowers, I specifically see radial tunnel syndrome in a lot. And then you can see overlap with other conditions like cervical radiculopathy and that. And I liaise a lot with, our neurosurgical colleagues like Michael Kelleher and people like that, where they'll say, I've been treating them for their neck and I'm not happy with what's going on. Do you think it could be something else? So I'll go and investigate further for them. And, you get this double crush kind of concept as well, where you can get issues with the neck, you can get issues with the nerve in the arm, or you can get tennis elbow, where there's a lot of other pathologies that can mimic each other. So it's good to, by the time they come to me, certainly we have to be out ruling other pathologies besides just tennis elbow.
Great, thank you. So second question, what is your thoughts on isometric loading for analgesical pain modulation?
Going back to the pain modulation, it's interesting that what I was saying was a lot of the patients think that this is an inflammation. It's not, it's degenerative. And as a result of that, the pain modulation seems to be a neuromodulatory problem. That's where the pain comes from. It's a mechanical problem as distinct from an inflammatory problem. And it's very hard for patients to get their head around that. So I always start them off with stretches. So no matter how bad their pain is, they can do their stretches. They can then build up to their stretches with a weight, and then their isokinetic, and exercises and things like that. And my problem for a lot of patients is they want to move too quickly, and get an immediate result, not realizing that they have to reload the tendon, retrain it, and that seems to help with the neuromodulatory pain receptors. So it's it's a concept that patients have difficulty getting around because they want a quick fix, and they've heard, it's my elbow is inflamed, and unfortunately that's not the case. So to get them into the place where they realize that it's going to take time, and they have to put their time in through a whole schedule of, exercises. And I say to them to treat their physiotherapist nearly like a personal trainer, where they get their program, they go off, do it at home, they practice it, and then go back to their physiotherapist again to bring them to the next level. So there's no quick fix. It's a program, and they need to be committed to that program,
Okay, thank you. So now, is there evidence for ESWT in tennis elbow, which is shockwave therapy?
Yeah, shockwave therapy.
Yeah.
A lot of people use it, and a lot of patients think it is helpful. There's various studies that have been, done on this, and you'll have studies that say it makes no difference and studies that say it does make a difference. I suppose looking at things like the Cochrane database, where they go through meta-analysis of various studies, they're the most useful. And unfortunately, the things that have been proven to make the most difference is your eccentric, stretching program and reloading the tendon. In terms of things like ESWL, dry needling and things like that, it's out there. People use it. Individual patients say it's useful, but it's not in the gold standard treatments, which for me is certainly exercise modification, a counterforce brace, your physiotherapy eccentric program, building up to your other programs then after that, and then injection therapy for pain relief, or PRP or like that. But the others are a little bit wishy-washy in the research side of things.
Yeah, you mentioned PRP there. So someone has asked, should PRP be image guided in tennis elbow?
I personally don't do any of my injections image guided, but that's because I'm trained as a surgeon in anatomy, and I operate, or I inject, where it is. If our radiologists and our sports medicine physicians are doing it, they often will do it under ultrasound guidance, and that is purely because that's what they're comfortable with. That's what they've been trained with, and that's perfectly fine. In my hands, I don't need it because I inject where I operate. Whereas in their hands, they're happy to do it. It doesn't make any difference, I think, to the long-term outcome, but it's just whatever the clinician is happiest with.
That's good. So what's the best management plan for an extensor tear that is slow to improve?
you have to realize when you're seeing a patient, you may have somebody who has symptoms but has no changes on their scans. And it's part of a spectrum. So it goes from somebody who has symptoms after chopping wood or doing gardening or things like that to somebody who has, you know, a long-term problem over a period of 6 months. Sometimes the people who have the micro tears and smaller tears are way more symptomatic. And then people who have massive tears are asymptomatic because the whole area has decompressed and they're going on with their life perfectly well, no problems. And that's why sometimes the scans can be misleading. Usually when I do a scan, it's not for the diagnosis or for the size or type of tear. It is to make sure we're not missing out other pathology that we should be treating. So the people who have sometimes the very symptomatic smaller tears, who are, you know, carpenters, you know, doing very physical work, who can't actually manage, they can't sleep at night or that they can't work, and have had a good course of rehabilitation with pain relief injections, counterforce braces, and have been committed to it, I would consider them for surgery. And I suppose that only equates to maybe 5% of the patients who present, which is good because this is a self-limiting condition. So you want them to do their program and work away at that. But certainly surgery is a good option for them because it gets back their strength, their power quite quickly. But the recovery period is at least 3 months. And, you know, it's a 90% success rate, but you always have to say to the patient, you know, if you're the 1 in 10 patients who's not that happy with it, you just have to let it burn out and let it all settle down. So they do need to take that on board, you know.
Okay. Anne-Marie, thanks very much for that. Okay, thank you. So thank you everyone for joining us. And just to remind you that if you need CPD points, there is the tab. Just go onto the tab and for your CPD points. And we wish you all well during this time. And we have got another educational evening next week if you want to log in for that. Thank you.